want to say a big thank you to Kath for firstly arranging this and then also for inviting James Butler and myself to talk. It's really a big privilege, I think, to really share your stories with you. And there are always heartbreaking moments, and then sometimes if something works, moments of joy. But I can just tell you that as a pediatric neurologist, I sometimes ask myself why I actually chose this. Because I think, generally it's but for the grace of God we go, and things are not always as fantastic as we would like them to be. And in the years of my work, I've been privileged to meet just absolutely fantastic and inspiring parents who just persevere in the face often of incredible odds. And it just has often made me incredibly humble, meeting people that just sometimes really simply take your breath away with what they can accomplish and what they manage. And I think there are lots of those amongst you here, so I really feel very privileged to be able to just talk about the ketogenic diet. And Kath has asked me to talk about when should we really consider it, when should we think about it. But I want to first sort of tell you a little story. Now I must just make sure that I press the right button. I just go down here. Just this one. Yeah, okay. To me, this story about the ketogenic diet has got the elements really of a fairy tale story, where the ketogenic diet kind of comes about, and I'll tell you a little bit about the history, and then through the course of time it actually gets a bit forgotten. It really becomes a bit of a Cinderella. And you know the story about Cinderella. She's actually meant to be a princess, but she's got a horrible stepmother, and she gets relegated to just cleaning floors and really leading a very lonely and miserable life until she is eventually released and claims her rightful place in life. And to me, the ketogenic diet story has actually really many elements of this, because it gets forgotten eventually, and then certain things happen across the way, and you've heard some of those stories. I'll just allude to them again. And it actually turns really into what I would almost call like a princess of treatment modalities for epilepsy. Well, every good story, fairy tale story, really needs to have a nice castle. And as you can see, this is a really spectacular castle. And you will probably look at it and think this looks familiar, but it is familiar because I think Hollywood, and particularly Walt Disney, they've really adopted this castle as their castle. It's a castle south of Munich. It's called Castle Neuschwanstein. And it was actually built by a king, King Ludwig II. And this king was quite an interesting man. He was very interested in art and beauty and philosophy and all kinds of beautiful things in life. And he built this castle. And a part of this, from this castle, he actually also built two other sort of equally spectacular castles. And if one looks at this castle from the outside, I mean, it looks spectacular, but if one walks inside, one cannot imagine how people built this and had so many things to sort of add and beautify those rooms inside. But one, of course, also wondered what this king was actually doing to his people, because he didn't seem to really be much concerned with governing his Bavaria. And I think the people of Bavaria eventually actually got a bit cheesed off with him. And the story goes that they really got rid of him. He eventually was actually declared insane. And he was found not really far from this castle, having drowned, so the story goes, but most people in Bavaria really feel that he was probably killed. Anyway, but to get on with our story that fortunately has a much happier ending, the story really goes like this. If you look back in time, in the 1920s, it was really a bad time to have epilepsy, and people have always had epilepsy. We've had epilepsy reports. We kind of can look back. Even the Greeks talked about it, and one really just wonders how people were treated. And I think the reality was that most people really weren't treated because there were no treatments available. But in 1912, there was a discovery of one drug that really made a big difference. It was phenobarbital. A lot of you will know about it. It's actually still used today. It actually kind of dates back as far as 1912. We still use phenobarbital today, but we try and use it only in emergency situations. We try not to use it as what we call a maintenance medication, or a medication that you're using on a daily basis, but it definitely still has its place. But so that was really one of the very, very, very first drugs that was actually used for epilepsy. And if you look back, it's actually just about 100 years ago. There were also other things called bromides. They were really quite toxic substances. One had to be very careful in how much you administered. You easily gave too much. You had to watch the child very, very carefully, and I frankly actually don't know how people really got themselves to actually prescribe this. But lo and behold, not too long ago, I actually had a child that came from Germany that was still using bromide, so I was quite amazed that some people really still stick to some of these old drugs that really had loads and loads of side effects. Well, the story goes on, and then in 1921, people make an interesting discovery. Somehow, there was a cohort of children who had, or a group of children who had epilepsy, and somehow they noticed that after starvation, and one kind of just wonders what really led to those children really experiencing starvation, and it was after World War I, so there was probably a really bad time in Europe, but the crux of the matter is that they noticed that after starving children with epilepsy, their seizure control seemed to be a lot better. And I think people in those days were really very, very alert, and you had sort of doctors and people really writing up stories and observing things very, very meticulously. So this didn't go by unnoticed. And somebody at the Mayo Clinic in Rochester, Minnesota in the USA decided to really study this phenomenon. And this man was called Wilder. And he was really the first man who then designed a diet that was going to mimic the effects of starvation on the body. And this really was the birth of the ketogenic diet. So it goes back as far as 1921. After 1921, people are using the diet, but it really is reserved for very severe refractory childhood epilepsy. And really for the next 20 years, this status quo is maintained. So the diet is used, but it is only used for people with, or for children specifically, who have very, very severe seizures, and they're very much using the classical ketogenic diet. And it's for the first time actually used, or there's a report about its use in adults in 1930. After 1940, many new anti-epileptic drugs emerge. So it's not only phenobarbital, but a big sort of a drug that makes its grand appearance is phenytoin or epineutin. And then follow quite a number of other medications. And medication really becomes the mainstay of treatment for epilepsy because it's much easier to give a medication. It can be, I guess, studied more easily, and it certainly becomes the preferred treatment for epilepsy. And the ketogenic diet really is almost forgotten, and it really turns into a Cinderella of treatment modalities for epilepsy. Then something happens, and you've heard the story in the Tribute to Meryl Streep video earlier onwards. You heard the story about Charlie Abrams. So how much longer, we looked at 1940, now it's 1993. And there's this 20-month-old boy with really severe, severe intractable epilepsy. And he eventually is seen at the Johns Hopkins Hospital. And people have tried all kinds of medications. He's had surgery. You heard the story of the parents. And everything has failed. He continues just to have lots and lots of seizures. So somebody remembers the ketogenic diet. And I kind of can just imagine in this meeting with all these very eminent neurologists at Johns Hopkins Hospital, somebody comes up with this idea about the diet, and he's probably shot down immediately, and people sort of argue with him that he must be completely crazy, this diet is definitely not going to work. But it must have taken one very brave person to say, no, but I have a gut feeling we need to try this because we've got nothing to lose. Here's a child, we can't help this child, let's try it. And as you've heard, I mean, Charlie responds within days. After having seizures all the time, this child suddenly responds within days. And his father, Jim, subsequently really starts the Charlie Foundation because he has this absolute urge to really share this incredible phenomenon with the rest of the world, to not just keep it to himself, but to make sure that word goes out there. So again, an incredibly brave parent who goes beyond himself in really trying to share what good has happened to him with the rest of the world, which is literally really what happens, because the Charlie Foundation is the first foundation to promote research into the ketogenic diet and really awareness of the ketogenic diet in general. So what happens then? I mean, from 1994 onwards, interest in the ketogenic diet is really reawakened, particularly in the United States. There are big symposia held 2008, a big symposium, which is really a big meeting in Phoenix, Arizona. Then in 2010, only 2 years later, there follows a symposium in Edinburgh in the UK. And if people feel compelled to actually have these symposia, it can only happen if you've actually got enough research material to present. You can't go and have a symposium, invite people from all over the world to come if you don't actually have to share incredibly good news with them. So you can just see what has happened there, how much research has happened, and how people really had a lot of fantastic evidence and sound scientific evidence to share. The last big symposium was in 2012 in Chicago, and I know that Kath went to this with, the support of her husband. So there was a complete explosion of research into the ketogenic diet, and as you've heard, it's used in many centers all over the world, and really the Cinderella literally now turned into a princess. Okay, so where does the ketogenic diet fit in? Dr. Butler alluded to it briefly in his presentation earlier on. If one looks at epilepsy, what are we dealing with, and what treatment modalities can we choose from? Epilepsy is the commonest childhood neurological disorder. So of all the neurological conditions that you can get in children, and there are many, epilepsy is really the commonest. And it's interesting where this name comes from. I'm always very intrigued by names. So epi in Greek really means upon, and then lambanein or lambanein, I'm not quite sure, I never did any Latin or Greek, so I don't know how to pronounce this, but that literally means to seize. And isn't that an apt description? Because you are really seized by something when you are having a seizure. So that's where the name comes from. So in terms of treatments, we've got anti-epileptic drugs. This is, and I have to apologize for those abbreviations that one just always uses. AED stands for anti-epileptic drugs. So we've got phenobarb, you heard about this, phenytoin, epineutin, valproate is epilim, carbamazepine is tegretol or trileptal. The benzodiazepines are Valium and Arum and Urbinol. Vigabatrin is Sabril, lamotrigine is Lamictin, levetiracetam is Keppra, there's topiramate or Topamax that I haven't even put on here. And there are a couple of others. So you've got all these medications. Then you've got surgery for selected children where the seizures really emanate from a specific localized lesion that you can safely remove. Then you've got the device that stimulates the vagal nerve stimulator. And now, for sure, the ketogenic diet holds its place amongst recognized, validated treatments for epilepsy. Just briefly, and I'm sure Cass is going to talk about it in a lot more detail, and she's got a lot more knowledge about this than I do, but I just thought I'd quickly just give you an overview. We are now talking about ketogenic diets because we don't just talk about one single diet anymore. And Cass will tell us about the classic or traditional ketogenic diet. This, up to now, probably still has most clinical data, but I think the modified Atkins diet that I'm going to talk about just now is really catching up quickly. We're looking at ratios of 4 to 1, so 4 fats to 1 carbohydrate and proteins, where you really derive 90% of your calories from fat, to 3 to 1 and 2 to 1, and accordingly your percentage of fat really reduces. And then Kath will probably also tell us where and which one is used. In terms of just generally speaking, the latter two are usually considered in infants or adolescents because in this group, children have different growth requirements, and one has to be cognizant of those. Then there's the medium, the MCT, standing for medium chain triglyceride diet. This has been used actually since the 1970s. It allows for greater proportions of your carbohydrates and proteins, and often makes use of the MCT oil. Then you have heard about the modified Atkins diet, published in 2003. Carbohydrates are restricted to 10 grams per day in children. Fats are encouraged, and in general terms, this diet is a lot less restrictive, and I'm going to talk about this again later, has really led to the diet also becoming generally a lot more acceptable, because it's easier to manage, and you also don't need to have the initial kind of period where you introduce the diet, where we often had to admit children, which really made the whole thing a little bit more complicated. The fourth type is the low glycemic index treatment diet. In Boston, it was published in about 2005, where one uses carbohydrates with a glycemic index less than 50. And all that this glycemic index refers to is really how the kind of carbohydrate, how quickly does it actually get released into the bloodstream. And one looks at carbohydrates that go into the bloodstream more slowly, and they're generally believed to be a lot more healthy because they don't cause dramatic swings in your glucose level. So So now, to come to this question, which children should be treated with a ketogenic diet, and when? How can one prevent a scenario where you actually really delay the use of the diet, and how can you make the right choices, literally? So I kind of thought what I'm doing now is and there are going to be quite a few abbreviations that I'm going to try and explain, and I'm going to also try and explain the words. But what I've found is that parents who deal with things often really become very adept at knowing all those words. A lot of you will have been on the internet, you research a lot of stuff, you often know more than we do. So I've kind of felt it appropriate to actually use some of those words, and we can talk around it. But what I did is I looking at where should the ketogenic diet be used, because we now actually have come to a point where we know certain conditions that are actually only treatable with a ketogenic diet, where no medication is going to help. Then to look at groups of seizure disorders where research so far has shown that the ketogenic diet is really likely to help, and one should really consider it early. Then to look at certain conditions where the ketogenic diet is really not going to help, and where you should not think about it. And then to look at certain conditions where the ketogenic diet really is contraindicated. So looking at the first group, where the ketogenic diet is really the only treatment option, there is a condition where glucose cannot get into the brain. So it's called a glucose transporter protein 1 deficiency, or for short GLUT1 deficiency. And because of deficiencies of certain proteins, glucose cannot get into the brain becomes hypoglycemic, or has got too little glucose. Glucose is the energy fuel for the brain, and the consequences of that are very problematic. You get epilepsy, you get slowing of the development or developmental delay. A very prominent feature is also that the head stops growing, so you kind of have a baby born with a normally sized head, but with this condition the head size the growth falls off. This is not the only condition where this happens. It happens in other conditions as well, but it is one of the notable findings in a GLUT1 transporter deficiency. You get movement abnormalities, you get spasticity, and there's a lot of research that is going into this disorder, because people actually have only really become aware of it over the last few years, and probably as recently as 2 to 3 years, where there's really much research going into this. And how to diagnose it? Well, sadly, we often only have diagnosed it previously because we would have a child with epilepsy and it would not respond to any of the medications. But by then already quite some time has gone by. You diagnose it by really also doing a lumbar puncture and looking at and comparing the glucose fraction in your lumbar puncture fluid to the glucose in your blood. And you can see that, relatively speaking, there is far too little glucose in the lumbar puncture fluid, because it just doesn't get into the brain. In neurology and in medicine generally, there's been an explosion also of genetic sort of research and genetic findings, and we're linking a lot of conditions with very specific abnormal genes. And in this condition as well, there is a gene that we can now look for that often is associated, which we can test for, but it comes, as usual with these genetic tests, at great cost. But it is an additional test that we can now do, and it really has only been available very recently. So in this condition, it's very important that the ketogenic diet is started early, and you need to maintain it well into puberty. Then there's another condition, and I don't want to go into much detail. It's a very rare condition. It's a mitochondrial disorder. Babies are often very sick from early onwards. They're very lethargic. They don't feed well. They've got breathing problems. And this is also something where we think ultimately the ketogenic diet is going to be the only modality of treatment that's going to work. Numbers with this condition, or there are fortunately very few children who have this condition, so people have struggled to really get enough numbers to really put a big trial together, but research is underway, and we think that ultimately the ketogenic diet is the only treatment that's going to help here. Okay, now what are then the conditions in epilepsy which are now found, following a lot of research, to be particularly effective? And one is something that many of you will have heard about, the Dravet syndrome, or severe myoclonic epilepsy of infancy. Usually we tell parents that myoclonic seizures, or these jerk seizures or drop attacks, are usually seizures where we have to then investigate very, very carefully, because they can come up in various syndromes, but invariably they are meaning that the seizures are probably going to be really hard to control. So one of these syndromes is Dravet's. Often you have very severe recurrent febrile seizures under 14 months, and what makes these seizures often different to ordinary febrile seizures is that they're already quite a bit longer. You often also get immunization-related febrile seizures. Later on you get abscesses, you get these myoclonic or jerk-like seizures. Developmental delay becomes apparent between 1 and 4 years. Again, a specific test is available, and what the research has very unequivocally shown is that the ketogenic diet here is really very useful and should be considered early, because it often also actually leads to an improvement in general behavior, and you can, what is hoped, that you can also kind of do something about the developmental delay. So one really should consider it there early. Then secondly, in Inducer syndrome, myoclonic atonic seizures, where you get early drop attacks and myoclonic seizures. Later on, there's a variety of other seizures that usually are also seen. And here we haven't got a specific genetic test yet. So here you really have to look at the type of seizures, the onset, and what else you see to kind of really make a diagnosis. So it's more looking at your symptoms and putting one and one together. And again, the early use of the ketogenic diet may also allow for tapering of other anticonvulsant drugs, and you're hoping that you can either maintain only on the diet or maybe with 1 or 2 other medications and not with 4 or 5 or more. What has been really very, very exciting is how the ketogenic diet has really been helpful in this funny condition called tuberous sclerosis, which is really a mouthful. But what often happens in this condition is that children very early onwards get very, very bad spasms. We call them infantile spasms or salam spasms. The syndrome is also called West syndrome, and it goes along with the condition very often where you also have specific abnormalities on the skin, and you can get these lesions in the brain that look like potatoes, and this is where this name comes from, tuberous sclerosis, tuber being a potato. So infantile spasms happen in a baby that has been developing normally, but suddenly it starts getting all these jerks every day. Parents usually immediately notice that that baby doesn't make good eye contact anymore, and development slows very, very quickly. And this is really a neurological emergency. One needs to try and get the babies out of this spasm situation as soon as possible. And it can be quite tricky to do that. The medications that have been used, ACTH is an injection that gets used, vigabatrin or Sabril is a medication. And that's still currently by the Big Tuberous Sclerosis Association suggested really as your first line of treatment for West syndrome. But there's so much exciting evidence happening with the ketogenic diet in infantile spasms that, for instance, the Johns Hopkins Hospital is certainly suggesting that one should really start this very early. And Kath and I have a mutual patient who has come from Durban and who wanted to be here today but can't, but where the diet has been, without a doubt, incredibly successful. This little girl is hopefully now, it looks as if development really is going on as expected, and the seizures, the spasms have stopped. What other conditions should one also think of, and where there's now evidence emerging that the ketogenic diet is working? Absence epilepsy, many of you will have heard about. We always ask about staring spells. It used to be called petit mal. And when that becomes refractory, there's evidence now that the ketogenic diet is helping. Landau-Kleffner syndrome is a syndrome where you get specific abnormalities in your EEG, often only during sleep. The first manifestation of this condition is often that your child stops speaking normally, after speaking actually appropriately for age, development of speech being appropriate for age, and suddenly there's a fall-off, and then you need to do an EEG at night, and it shows these terrible slow discharges during sleep. And here the ketogenic diet seems to also be effective. Then there are other conditions, Batten's disease, fortunately very rare. But then another condition, febrile infection-related epilepsy syndrome, where a normal child suddenly has very high temperatures and incessant seizures. One looks for a cause. It doesn't seem to be a viral or bacterial cause. One can often really, really struggle to get control of the seizures, but here the ketogenic diet can also work. Then in malformations of the brain, there's lissencephaly, where the surface of the brain is abnormally smooth, or this condition of bilateral perisylvian polymicrogyria, where you again have areas of the brain surface that look completely abnormal. And curiously, the diet again here in focal abnormalities really seems to be very promising. And then lastly, a condition that often causes a lot of grief, something called hypoxic ischemic encephalopathy, where the brain really gets damaged if it, for whatever reason, hasn't been able to kind of get enough oxygen. So that happens in near drowning episodes. It happens in term babies that get born that have a very catastrophic birth. It can happen in other injuries where basically you're prevented from breathing and oxygenating your blood. And often disastrous seizures are a consequence. And the ketogenic diet has really also proven to be very promising in this condition. Where is the ketogenic diet not likely to be effective, or where has research shown that other treatment modalities are definitely superior? This is what happens in children who have partial seizures, who have been worked up and who've been found to be candidates for surgery. So I think in children who've got a very specific lesion, for instance in the temporal lobe, it really makes sense to take that lesion out. And the outcome is clearly superior there to continuing, leaving the lesion in and just continuing with the diet. So I think in those circumstances one wouldn't recommend the diet. Where should it not be used? Well, there are very specific metabolic conditions where the body is not going to be able to handle the fat load that comes with a ketogenic diet. And I mean, these are just a couple of conditions that are very rare, fortunately: pyruvate carboxylase deficiency, fatty acid oxidation defects, something called the primary carnitine deficiency, a condition called porphyria that is not always associated with epilepsy, but there's a specific type that can be, and then some form of these mitochondrial disorders that we're looking for. So in those kind of conditions, we know that the system would not be able to deal with the metabolic changes that the ketogenic diet brings about, and we would not introduce it. What has been really quite exciting is that if one looks at papers on the ketogenic diet, is that there seems to be also application for it in non-epileptic conditions. And there's research happening now with respect to the diet in Alzheimer's disease and Parkinson's disease. No conclusive evidence yet, but certainly some exciting work emerging that indicates that it's at least worthwhile looking at in those conditions as well. So to end off, there are some important take-home messages here. I think one of them is that the ketogenic diet really used to have a really bad name, and it used to be sort of the last resort. So if all medication really fails, only then is it worthwhile to look at the effort and the trouble and the work and the hardship involved in introducing the diet. There was concern initially that we had to admit children to hospital, which kind of exposed them to whatever else was going on in hospital. There were worries initially with the initiation of the diet with a low blood sugar or with dehydration or with other metabolic derangements. And I think that all contributed towards making the diet a lot less attractive and actually even quite dangerous. And I think people were always worried about exposing children to really very heavy fat loads, particularly also in South Africa, where we have a lot of familial fat protein metabolism abnormalities. And I think that all really compounded the problem that the diet was not thought of as an initial treatment option. And I think also the research was not yet there that was really supporting it. It's important to know that really the ketogenic diet is an only treatment option for certain conditions. And then I think it's really important that so many bad refractory epilepsies, which mean epilepsies that are not responding to treatment, show very, very promising response to the diet. Also West syndrome or infantile spasms, which is not an uncommon condition, and one really has to think about the diet early. And to really think about it, and as the research kind of moves on, I think it should probably be considered as an option to discuss with parents. Really, when one sees somebody with epilepsy for the first time, one really has to take that ketogenic diet out there and mention it so that parents can get information about it. Proper monitoring and supervision is absolutely vital. And to end off just in terms of kind of following the storyline, I mean, you know, you've had a story, there was a story about the castle, there was a story about Cinderella turning into a princess, but each story that has a fairy sort of tale story element to it really also needs to have a fairy. So, who's the good fairy in this scenario? I think without a doubt, the ketogenic diet really is managed by an experienced dietitian. Without a dietitian, this doesn't work. We as doctors have not nearly got the knowledge and the experience that a dietitian has. We can just talk about the diet in general terms, the nitty-gritty, the what do I do now, how do I change this, what recipes do I use, how do I even implement these recipes, what and how. Really, this is where your dietitian comes in. And I think we are incredibly privileged and very, very fortunate in Cape Town that we've got Cass around. And Cass, you really deserve an enormous round of applause, because I think you were very good. And I guess that goes for saying Cass and her team and her husband and everybody else around it. Okay, but just to come back and make sure that you realize that this is all grounded in reality. This is not story, like James said. This is hard, cold, true scientific fact. There are a lot of references here that I looked at here. I mean, Dr. Kossoff from John Hopkins is clearly one of the forerunners. He is very, very prolific. He publishes fantastic work in very, very high quality medical journals. I mean, there's one of him. I can't point. But anyway, just to make sure one really appreciates this is really science, and this is really worth the cause that you've all embarked upon. Thank you for listening.